My name is Rani Maskatia. I'm an allergist and I specialize specifically in people with food allergies right now. So I want to give you a talk about food allergies and also update you on some of the more recent developments in the field. Afterwards, I'm happy to answer any questions anyone might have. So I wanted to start out by speaking a little bit about the impact of food allergies because it's pretty striking. About 1 in 13 kids currently has food allergies. That translates into about 2 in every classroom. Of course, food allergy is a very big deal, but the rates weren't always this prevalent. Really, in the last few decades, we've really seen a marked increase. According to the CDC, the prevalence of food allergy in kids increased by about 50% between 1997 and 2011. And between 1997 and 2008, the prevalence of peanut allergy actually tripled in US children. Even though we mainly associate food allergies with kids, it's important to remember that this affects adults as well. And a recent study did find that over 10% of adults also have food allergies. And the financial impact of food allergies is staggering. The cost is estimated to be about $25 billion a year in the US alone when you take into account lost work productivity and ER visits and rescue meds. So of course, food allergies do encompass peanut allergies, but it's more than just peanuts. So 90% of food allergies are caused by 8 foods. So those are peanuts, tree nuts, milk, egg, wheat, soy, fish, and shellfish. About 23% of people with food allergies do have a peanut allergy. 30% of patients are actually allergic to more than one food. And it's always important to remember how serious food allergies can be. About 40% of children with food allergies have suffered a life-threatening reaction. So when it comes to potential causes of food allergies, this is really an area that we need a lot more studies and research. So we don't have a clear picture as to why food allergy rates have increased so dramatically in recent years, but we do have some ideas. So we know that eczema is a risk factor for food allergies. Basically, the thought is that if a kid has eczema and has breaks in the skin, their first exposure to foods would be through the skin, and that can actually be sensitizing and promote things like food allergies, versus if that first exposure is through the mouth and gut, then that's actually protective against food allergies. And we do also have good evidence to show that having more diversity of foods early in life can be protective against food allergies, and I'll talk about that a little bit later in the talk. There's a lot of other hypotheses out there. You may have heard of the hygiene hypothesis. This is the idea that a lack of exposure to bacteria and microbial factors is the reason that allergy rates are increasing. There have been a lot of studies on vitamin D. Most of them have associated vitamin D deficiency with food allergies, but there are some conflicting studies showing higher levels of vitamin D also to be associated with food allergies. Environmental factors are likely at play. We know that things like living on a farm or having older siblings in general are associated with lower rates of allergies, but of course that's not absolute. There's a lot of research right now in the microbiome, which is the bacterial composition of the gut, and how that may impact allergy risk. So I wanted to spend a little bit of time talking about food allergy versus food intolerance because they're very, very different things. Food allergies involve the immune system. They can be life-threatening. They involve a specific type of antibody in the blood called IgE, which interacts with allergy cells and causes symptoms like hives and swelling and breathing problems. Food intolerance, on the other hand, is not life-threatening. It usually causes digestive issues, bloating, or stomach pain. Some examples include things like lactose intolerance or irritable bowel syndrome. But these are very, very different things. At our clinic, we really do focus on IgE-mediated food allergies. So diagnosis of food allergies is actually notoriously difficult to do. We do have allergy tests that measure those IgE antibodies. Unfortunately, we get a lot of false positives with our tests. And so positive tests alone do not diagnose a food allergy. That's really important to remember. You actually do need a convincing clinical history plus the evidence of those IgE antibodies, which can be found through skin testing or through blood testing. And if there's ever any question about the diagnosis, then we do perform oral food challenges in the clinic where we actually give the patient increasing amounts of the problematic food to see if there's an allergy present or not. So how do you recognize a food allergy reaction? Of course, there's symptoms like hives and swelling, but a child may describe those in very different terms than what an adult might. So a child might state that their tongue itches or that it feels hot or burning. I've had kids say that it feels like something's poking their tongue or that there's hair on it. Some will describe their mouth feeling funny or there's something stuck in their throat. I had a kid tell me there's a banana in his throat is what it felt like when he was having a food allergic reaction, or his lips felt tight, and a lot of them will say there's bugs in their ears because they will get that ear itching. And so these are just different ways that a kid might describe a food allergy reaction. So this is all stuff that maybe you already know, but it's very, very important, and so I did want to just bring it up just so everyone is aware. So the treatment for anaphylaxis is always epinephrine. Epinephrine is very safe in the setting of anaphylaxis, but it's often underutilized. And important to remember that up to 30% of patients with anaphylactic reactions may actually need more than one dose. So when you carry epi, we ask that you carry 2 at a time. And so antihistamines are also very effective for allergic reactions, but they are second line. They do not treat anaphylaxis. They treat skin symptoms like hives and swelling very well, but they do not work for the respiratory and circulatory symptoms that you can see with more severe reactions. That's always epi. And in our clinic, we actually do use a longer acting formulation. Before, we used to always say use Benadryl. Benadryl, we thought, had a much quicker onset of action as compared to some of the other antihistamines, but they actually did a comparison of Zyrtec and Benadryl, and they found they have a very similar onset of action, and Zyrtec or cetirizine has less side effects overall, so that is the one that we prefer. So we're going to spend a little time talking about the natural progression of food allergies, because it turns out many food allergies can actually be outgrown. So the main ones that can be outgrown include milk, egg, wheat, and soy. Nuts and seafood, unfortunately, are much less likely to be outgrown. Current studies suggest only about 20% of kids will outgrow a peanut allergy, and it's even less, about 15% or so outgrow tree nuts, and seafood actually has the lowest rates of outgrowing. So I'm going to spend a little time talking about prevention of food allergies, because there really has been some exciting research that's been done in the last few years that suggests that there are things that we can do proactively to try to prevent food allergies from forming. So previous guidelines had actually recommended avoiding allergenic foods in the early years, but now we know that that was probably the wrong advice. We have a lot of evidence to suggest that early introduction of certain foods in infants may decrease the risk of developing an allergy to that food, especially in those higher risk infants. When I say higher risk infants, those are usually the ones that have significant eczema, especially if you need to use a prescription cream to treat that eczema. And so the landmark study here really was done by Dr. Gideon Lack. He was a researcher who noted that in Israel, rates of peanut allergy amongst babies were very, very low as compared to Jewish kids that grew up in the US or in Great Britain. And one thing that was very different between those two groups of infants is that in Israel, they did feed their children this snack called bamba. It's a peanut snack. And he wondered, was it that early introduction to peanut that caused those differing rates? So he actually designed this very nice study where he did take those higher risk infants with moderate to severe eczema, and he actually split them up into two groups to either avoid peanut, which was the current recommendation at the time, or to have early peanut introduction. And they did find that early peanut introduction decreased the risk of developing peanut allergy by 81%. And so all of the guidelines really changed, and now it is recommended, especially for those higher risk infants with eczema, that they be introduced especially to peanut at a young age, as early as 4 to 6 months. So the last part of my talk will focus on options for food allergy care and treatment, because the good news is there are things that can be done. So to be clear, the standard of care is still avoidance and carrying an EpiPen, but for a variety of reasons that may not be the right option for all families. Accidental ingestions do happen, and quality of life can be markedly affected by trying to strictly avoid foods that someone is allergic to. And so there are some options. I'm going to be talking about oral immunotherapy immunotherapy in the most detail because this is really the treatment that has the most evidence behind it. And so my next slide will address that. But there are other things as well. So epicutaneous therapy, you may have heard of the peanut patch. This is basically a way of introducing allergen through the skin. And there is a peanut patch that hopefully should be coming out in the next 2 years or so. In addition to that, there's sublingual therapy. This is actually food protein dissolved into a liquid and administered under the tongue. Both of those are showing effectiveness, not as effective as oral immunotherapy, but they are hopefully, some options that should be available. So while there's no cure yet, there are these treatment options that offer an alternative to avoidance and can improve quality of life. So I'm going to spend a little bit of time talking about oral immunotherapy in particular. So what we do with immunotherapy in general is we're trying to teach the body to no longer react to the thing that it's allergic to. It's the same idea as allergy shots, but with foods, we don't use injections. We actually use the actual food. So we start by giving a super teeny tiny amount of the thing that the person is allergic to. And over the course of many months, we actually increase that amount. And through that, we teach the body to no longer react to the thing that it's allergic to. So the patient becomes desensitized to those allergens. This has been done for many years. Thousands of patients have been treated in both private practice and in clinical trials. It's been found to be about 80 to 85% effective. So the benefits of oral immunotherapy include protection against accidental ingestions. We also have many studies suggesting that oral immunotherapy improves quality of life for food allergic patients, including improved social, emotional well-being, and improved variety in the diet. Allergen avoidance diets can result in reduced height and BMI, especially when avoiding milk or multiple foods at once. But of course, as with anything we do in medicine, there are also risks to treatment. With oral immunotherapy, we are giving someone a food that they're allergic to, and the major risk is that of an allergic reaction. The majority of these are mild, and they mainly involve the GI tract. However, it's important to know that anaphylaxis can occur, especially during the updosing phase. And we do go over several strategies to try to reduce the risk of reactions, including a rest period after dosing, taking the dose around the same time each day, and decreasing or even stopping the doses during an illness. There is also a risk of developing a condition called eosinophilic esophagitis. This is a disease that causes inflammation around the esophagus and results in difficulty swallowing, abdominal pain, and vomiting. Studies suggest this occurs in about 5% of patients undergoing oral immunotherapy. So really, my takeaway points are that positive tests alone do not mean that someone has a food allergy. It's really important to find someone, ideally a board-certified allergist, to properly interpret those tests, and in the cases where there's any question, to perform an oral food challenge. Now we know that early introduction of allergenic foods is recommended to help prevent food allergies, and we know that there's still more progress to be made. There's lots of improvements we need with regards to diagnostic techniques or prevention. We also need more targeted therapies. But there are treatment options that are available now to help improve quality of life. This is my contact information. As Jung mentioned, we are part of a clinic that focuses entirely on food allergies. We're located in Redwood City, and I am happy to take any questions.